Good afternoon and welcome to our Healthcare and Careers Focus webinars. These have been put on by the East of England Health and Care Academies for students and young people interested in a career in health and social care. Today's session has been allied health professions, and joining us today is Uttam, an occupational therapist, Clare, a speech and language therapist, and Jessica, who works in podiatry. Thank you for joining us today, and I'll hand over to our first guest speaker, Uttam.
Hello, so my name is Uttam and I am the OT professional lead at Hertfordshire Community NHS Trust, and I'm here today to give you an insight into my current role and the OT profession. Next slide, please. So I've been working as an OT for just under 10 years, and it all started with me gaining a postgraduate diploma at London's South Bank University. This was a 2-year accelerated course, as I'd already acquired a relevant undergraduate degree before. However, you can also gain an OT qualification by completing a OT undergraduate degree, which is typically 3 years for full-time or 4 years for part-time students, or via an apprenticeship. As I work through this slide, you'll notice that I've mentioned bands and bandings a couple of times. In the NHS, we have a banding system which reflects the role and career experiences and rates of pay for staff. So just to give you a bit of context. All right, so once I've gained my qualifications, I was able to join on a Band 5 rotation, and rotations are a great opportunity for professionals at the start of their career to acquire new skills and learning experiences by working in different clinical settings and teams. So I did this for around 15 months, and I moved on to the next stage of my career, which was a Band 6 rotation. So this was a slightly more senior position and remained there for another 2 years. Once I knew the field I wanted to specialise in, which was in community rehabilitation, I decided to remain in static or single posting roles as a Band 6 and Band 7 for a couple of years. And finally, I'm now where I'm at. For the last 7 months, I've been in my current role as the professional lead OT, which I'll talk about in the next slide. Thank you. All right, so I'm currently working in a strategic leadership role within my organization, where I'm responsible for the professional development of the OT workforce. I'm not currently involved in direct clinical work, but a typical day may include providing supervision in single supervision or in groups, training and meeting with other OTs to better understand the challenges and the positive work that they're doing in the front line. I will also be involved in planning job adverts and carrying out interviews. I also have a key role in working in partnership with key stakeholders that will result in efficient processes for staff and improving patient care. Now, I just want to reflect on when I was working as an OT in a frontline clinical role. Typically, as an OT, you'll be responsible for triaging new referrals, completing initial assessments with your patients, prescribing equipment, and delivering rehabilitation in the community. In my previous role, I was also a former team leader, so I was responsible for managing a therapy team. Next slide, please. So this is a very proud achievement in my role. This was a picture taken of colleagues within my organization just a month ago. So OTs during OT week. This was a week in which the profession used the opportunity to celebrate and highlight the profession. We used this opportunity to network and also participate in specialist training. Next, please. So occupational therapy. So the OT profession helps people of all ages and backgrounds overcome challenges in completing everyday tasks or activities, what we call occupations. We create a plan of goals and adjustments targeted at achieving a specific set of activities. This support can give people a renewed sense of purpose. It can also open new opportunities and change the way people feel about the future. Now, with me, I spent majority of my career working within what we refer to as physical settings or delivering rehabilitation in the community. So quite often, as occupational therapists in this setting, we are linked with provision of equipment that you would typically see around the bathroom, toilet, staircases, or adaptations made to the property. By helping people live well for longer, occupational therapy saves money and reduces pressure on health and social care services. And it's quite important to know that us OTs, we work with the multidisciplinary team, and we are one of many allied health professionals that work within health and social care. Next, please. Now, this is a video clip produced by the Royal College of Occupational Therapists. It illustrates the lived experience of a patient who experienced a traumatic injury and her journey through rehabilitation and her experiences of working with OTs. Thank you.
I'm Melanie Reid. I'm a journalist, a writer with The Times, and 14 years ago, when I was 52, I had a spinal accident. I'd ridden all my life. My son had only just gone to university, and I only just had time to kind of get a good horse and try and do something a little bit more ambitious. And I fell off over a practice jump. The horse refused. I went over his head, went over the jump, landed on my face, and my body flipped over, and it sort of essentially, broke my own neck. There are many sad stories about people who can't carry on with the spinal injury, but I personally carried on because of my family, and that's what counts. But excuse me, but the therapists here are what. Without them, I couldn't have done it.
My job purpose was to try and help people get the best function from their hands and their arms after their injury. Although the hand therapy was my actual treatment intervention, there was a lot more attached to that. The wheelchair skills and the changing her balance and just making sure she was able to make herself comfortable. The aim was to try and make her as independent as possible.
My first memory, I was in high dependence, it was you, and nothing worked.
I came and did your assessment before you were actually aware of it. Did talk to you, didn't get a lot of response or a lot of sense.
It was the morphine.
Occupational therapy is paramount in supporting individuals to gain their independence back into their lives following a traumatic injury such as a spinal cord injury.
After 3 months, for the first time ever, I was able to move from the physiotherapy plinth, slide into my wheelchair. And it was like, there was a big cheer went up, and it was like, Mel's done a transfer, because that was the gateway to a semi-independent life. But without the occupational therapist, it wouldn't have happened.
For Melanie, she was quite adamant she didn't want to move, and we'll do everything we can to see what potential her accommodation has to be adapted. We had to look at lots of small internal ramps to allow access in and out of a variety of rooms. We also needed to convert her bathroom to a wet floor shower area.
Every day Amanda was working with me. She showed me how I could still make food for myself and how I could boil kettle and make a cup of coffee and dress myself.
She's a very special lady. I feel very privileged to have had the opportunity to work with her and get to know her.
Both Amanda and Leslie, they were right at the front line for me, and they've remained mates. I mean, I don't see them from year to year, but I know they're there.
So that was quite a powerful video showing you the power of occupational therapy. I must say that in this particular video, it illustrates a patient accessing services in an acute setting. It's important to note that as an occupational therapist, we can work across many health settings, so acute, in the community, working with people with learning difficulties, people with wheelchair users, in social services, in schools, in prisons, etc. So the scope for practicing as an OT is quite varied in the current climate. Now, rewards and challenges. I would say supporting and enabling patients to achieve greater independence and better health outcomes, as best illustrated by that video, is one of the biggest rewards of the role. In my current role as a leader, I find it very, very rewarding to deliver training and developing staff, which results in highly skilled workforce and a happier workforce. In terms of challenges, the NHS and social services, they are a complex system, and I would say it's taken a fairly long period of time to understand the processes for equipment ordering and onward referrals within the NHS and social care. Next slide, please. Advice to my younger self. So I would say if I had to rewind, I would look at shadowing other professionals and other teams to better understand the role of the OT and the career prospect of being an OT within the specific service, but in general as well, looking at the career prospects as an OT within health and social care services. I would firmly advocate for rotations. They're a great opportunity for continuous learning in the early part of your career. And I would say throughout, take some time throughout your career to develop yourself. And that includes attending any training courses that are relevant for your role at that particular time. And that will help you in good stead in the future. Thank you.
Thank you, Uttam. So joining us now is Claire, who's a speech and language therapist. Thank you, Claire.
Hello, yes, my name's Claire. I'm a speech and language therapist. I work in the West Essex adult community team. So I work in people's homes, in care homes and in clinics with people that have got speech and language and communication difficulties and also swallowing difficulties. Next slide, please. So how did I get into speech and language therapy? Well, I started, I think when I was choosing my career, when I was a teenager, I'd never heard of speech and language therapy. And I originally went to university to study English literature. And after that, went into a job in book publishing. After a few years, I realised that I wanted to work in the healthcare setting. I wanted to do something that was more of a caring role, something that helped people. And I started researching what sort of healthcare roles could incorporate my interest in communication and language. And that's when I came across speech and language therapy. The first time I applied to university to study speech and language therapy, I didn't get in. So I went away and did some volunteering and applied for a job as a therapy assistant. So this is a really good way to get an insight into different types of allied health professionals. So I worked as a therapy assistant with occupational therapists, physiotherapists, and speech and language therapists. Then with that experience, I reapplied for the speech and language therapy masters at UCL and got in. Following qualification, I got my first job at the Royal London Hospital on the wards. So I worked as an acute speech therapist. Then after maternity leave, I went into the community stroke team, so specialised specifically working with people with stroke. And then more recently, I branched out again into a general adult community team where I work with not only people that have had strokes, but lots of other neurological conditions and some other conditions such as respiratory conditions as well. And that's where I am now. Next slide, please. A typical day for me, I would start with, often we have a team meeting. I work 3 days a week, Monday to Wednesday, and we have a weekly team meeting where the rest of the speech therapy team meets up on Teams to discuss any team issues and check in with each other. Then I might prepare for my appointments, look at the patient's notes and think about what I'm going to do with them. Then an example of a day would be 4 home visits where I might go and see somebody to assess their swallow and communication after they've been recently diagnosed with motor neuron disease. Then I might go on to see somebody who had a stroke several months ago as part of a therapy treatment package to rehabilitate and improve their speech and language skills. Another common visit that I might make would be to a care home to observe lunchtime for somebody that's got advanced dementia and they've been referred to me because they are coughing uncomfortably when they're eating and drinking and holding the food in their mouth. And then another typical visit might be to see somebody who has Parkinson's disease. For example, somebody that's had it for several years, but recently started to notice a change to their speech and swallow. So I would go and assess and give advice. Then after the visits, I would go back home or back to my hospital base to complete my documentation, reports, and any other admin that I had. Next slide, please. Rewards and challenges of my role. I really like meeting and getting to know a diverse range of different people and also learning about lots of different medical conditions. It was one of the things I enjoyed most when I moved away from book publishing, where I felt like I was in an environment where everybody was very similar to me, had very similar upbringing. And then suddenly I was seeing people from all sorts of backgrounds with lots of different experiences, lots of different ages. And I found that really interesting and exciting. And of course, I love working in therapy. You can often hope to see and expect to see some improvements in either the actual skills of the patients you're working with or just their confidence and knowledge of what they need to do. And that can be very uplifting to see improvements. And having said that, I will work with people who aren't necessarily expected to get better, and they may be expected to get worse with certain progressive conditions, but I still find that very fulfilling, and there's a real sense of satisfaction in helping people when they're going through a very, very difficult time. So I do enjoy that sense of helping other people. And then with speech and language therapy, there's a lot of scope to use your creativity and problem solving skills to try and personalize what you're doing to help the individual that you're working with. On the downside, the challenges working in the NHS are the long waiting lists. In an ideal world, it would be lovely to see everybody as soon as they were referred, but often people do have to wait a long time for our services, which is a shame. And it can be, as you can imagine, working with people that have long-term conditions, it can be quite mentally and emotionally challenging. But I think that also adds to the sort of sense of meaning and satisfaction in doing the job. Next slide, please. So looking back at the beginning of my career, my advice to my younger self, I'm thinking particularly when I was starting to volunteer or working as a therapy assistant, learning about the job, I would advise myself to always ask lots and lots of questions. Make the most of the fact that you're not expected to know everything. Ask all the stupid questions. I would say to make a really good impression, introduce yourself to everyone, be that sort of friendly face in the department, and people are usually more willing to help you and support you when you do that. And to ask for help. So it's always a learning curve going into your first healthcare professions job, and all the sort of theoretical training in the world can't fully prepare you for working on the wards or working with the people with complicated conditions. And so I always advise people to ask for help from more experienced people. And even now that I'm more experienced, I still ask for help from my colleagues, and we try and work together to solve difficult problems. And then just remembering that little things make a big difference. So by that, I mean, even when you're less experienced, there's little things that you can do. For example, just giving someone a bit of information. I always underestimate how important it is when I meet someone to explain how speech and language works, to explain how swallowing works, and how that relates to the condition that they have. Sometimes a little thing, just like explaining something to them that might not have been explained before, can really help them in sort of acceptance and understanding what to do. Next slide, please. So this is I'm going to talk through a case study, an example of the kind of person that I might work with on a regular basis. So this case study is a 60-year-old woman with Parkinson's disease. Now, Parkinson's is a progressive neurological condition. So this is a condition that causes problems in the brain and is progressive, so it gets worse over time. And speech and language therapists often work with people with PD because it impacts their voice and their swallowing as well. So some typical changes to voice and speech might be sounding more slurred, having extra slow or sometimes actually extra fast speech, which impacts on how much you can understand them. It can change the quality of your voice, it can make your voice sound more hoarse. It might make your voice and your speech sound monotone, so it affects that expression when you're talking. It might cause difficulties pronouncing words, it can cause tremors, and also very quiet voice. Often people with Parkinson's, their voice and their speech becomes more quiet over time. Next slide, please. So for this case study, the background is this 60-year-old woman. She was referred to the speech and language therapy team by a specialist Parkinson's nurse who had been seeing her and had noticed that her speech was quite quiet and that her voice sounded quite rough. She lived at home, and recently her husband had been unwell and had gone into a care home. She'd had the diagnosis of Parkinson's disease for a couple of years. Sorry, she'd had the symptoms for a couple of years, but had only just got the diagnosis. And that can be quite common, that symptoms can start and it takes a while to get the diagnosis. And she had a reduced social life because she also had mobility difficulties, making it hard to leave the house. She, over time, was lacking in confidence, and she said to me that she often felt she was being ignored by other people. And she used to sing in a choir at church, and that was something that made her very happy, but she no longer felt that she could do that. Next slide, please. So what I did as a speech and language therapist was to assess her speech. So to have a little listen to her speech and ask her to do specific speech tasks, to listen across a variety of situations, and also ask her lots of questions about how her speech is impacting her life. Then what I found was that her speech had become more quiet, but she wasn't aware of that. And that can be very common with Parkinson's disease, that your speech can become quiet, but you're not able to monitor your speech and notice that it has become quiet. So I gave her some education about this and how Parkinson's disease impacts speech, just to raise her awareness that actually her speech had got quiet over time compared to before, and that might be why she was noticing these feelings of people ignoring her, because people weren't hearing her in the same way as they were before. We involved her family in this discussion, and this was really, really helpful because the family weren't aware of her feelings of lacking confidence, and that raised their insight into what was going on for the woman. So we helped her identify some goals, and we trialed some strategies. There's a particular strategy which we called Think Loud technique, where we practice increasing the loudness of speech. And this not only makes it easier to hear, but it also improves things like breath control and articulation, and also voice quality. So that was very successful with this woman. We practiced this strategy and measured the success of it. Then I also saw my role as a bit of a coach to try and empower and motivate her to continue practicing the strategies, to use the strategies outside of the therapy sessions in her real everyday life. And she became very skilled in the strategies and was able to carry them on independently. At that point, she was discharged from speech therapy with kind of information about how to be re-referred in future if she needed us again. Next slide, please. Our multidisciplinary working, something I really like about working in healthcare is you do get to work with lots of other professions. And in this sort of case, we would work closely with the GP. We often get a lot of our referrals from the GP. We would work with specialist nurses. So in this case, liaising with the Parkinson's nurse. As I mentioned, we worked with the person's family. She was also being seen by a physiotherapist, and she also had carers that came in regularly. So these are all the other professions that I would come across on a daily basis and share information and work together. Next slide, please. So the results of working with this lady were objective increase in measurements of loudness. So her voice actually got louder. She was able to make her speech louder than it was before. The quality of her voice was clearer as well. And there were improvements in her articulation. So her voice and her speech sounded less clear, less slurred. Then the things that were really important is how this impacted her everyday life. So she did really notice a reduction in people asking her to repeat herself, which is a real benefit to her. And she felt more confident in social situations. She was telling me that she felt more confident seeing friends, particularly in group situations. Her family were better able to understand her condition and made more efforts to include and support her. And she also started singing again in church, which was one of her goals. Next slide, please. Yeah, so that's just a little snippet of the sort of person that I might work with regularly as a speech and language therapist, but you can specialise in lots of different areas. And this slide is to show you the range of conditions and the range of different people that you can work with as a speech and language therapist. Usually in your training, you learn about everything, and then initially you choose whether or not you want to work with children or whether you want to work with adults. And then you might stay quite broad in those areas of pediatrics or adult work, or you might specialize in particular conditions such as learning disabilities or head and neck cancer or neurological conditions. So it's a really varied career, and you can do a lot of different things with your training. And that's all from me.
Thank you, Claire. So, we now move on to Jessica, who works as a podiatrist. Thank you, Jessica.
Hi, hello. Okay, so podiatry is one of the allied health professions. I come from East London University. It's the only university in London who offers the course. I studied for 3 years, and unfortunately, I graduated the day before COVID stroke. So I was thrown into a deep end on my first year of as a band 5, because normally a newly grad you start working as a band 5, and we were on lockdown, so the NHS was very different back then. So as a normal band 5, you were slowed into the career. I was thrown into the deep end because all we were seeing at the time was wound care. So I became a very good specialist in wound care. So I'm now a band 6. I'm a specialized podiatrist, and I often do wound care. So podiatry, what is a podiatrist? Often people ask the question, what's the difference between podiatrist and chiropodist? And there's no difference, not in the UK. Before podiatry became a degree, and we have the Royal College of Podiatry, used to be called a chiropodist, because back then it was just apprenticeship. And once it became a degree, we changed to podiatrist. So it's a very sought after profession because we are very small cohort. Unfortunately, it's a profession that needs more professionals because not many people, funnily enough, are interested in treating feet. So it's a profession that needs more and more staff. And therefore, if you're graduating as a podiatrist, you are very likely to get a job position either in the private sector or in the NHS. Both areas are really fighting over podiatrists. We look after feet, ankles, and lower limbs. So we are specialized from the hip down. And in the NHS especially, we look after people with chronic illnesses. So that could be MS, multiple sclerosis, diabetes, arthritis, congenital disorders that causes hyperkeratosis. In the past, unfortunately, now we can't accommodate these patients anymore, but in the past, we used to be able to treat everyone and anyone that needed us. Let be like an elderly person that can no longer reach their feet to cut nails and debride corns and calluses. Nowadays, we are focusing more on chronic illnesses, and our main job is to prevent limb amputation and to save lives. And that majority, it's because we are so small. We are a small body, and unfortunately, we are a small team, and we can't provide care for everyone. So we are having to select the most serious cases of patients that need our services. We work very closely with doctors, nurses, and other allied health professionals. Often we're mistaken we're mistook by nurses. We're not nurses. We are a different body. We're podiatrists. But often patients call us either doctors or nurses. We're either. It's a very medical profession, and we not only can diagnose, treat, but also issue medications. We can perform minor surgery like small nail avulsions or partial nail avulsions, but we can progress our career to become even podiatric surgeons. Yeah, so you can become a surgeon and provide bunion surgery, straighten hammer toes, and those are band 9. So it's from band 5 all the way to band 9 in the NHS band pay scale. As I said, we can administer and we can provide medication. We can become an independent prescriber, and that would be an extra course that you would have to do. But we have in the allied health profession called POM-S and POM-A. So POM-A would be to be able to administer medication like local anesthetics for neurosurgery. And POM-S, we can supply medications, and there is a certain amount of medication that we could supply, like antifungal treatment, antibiotics, a small section as well, so we can provide that. And our aim is to give quality of life for patients with chronic illnesses in the NHS, and also for other illnesses like verruca in the private sector, musculoskeletal conditions like plantar fasciitis, some Achilles tendinopathy, some tendinitis. We provide all that in the private sector. We can, in the NHS, as I said, we focus more into the MSK, the musculoskeletal, and the wound care. Next slide, please. So in the NHS, we have 1.3 million working in the NHS as a cohort. Many podiatrists, as I said, in the NHS, we do more wound care, and we work very closely with a different type of, like I can refer a patient to a lymphedema clinic, I can refer a patient for a leg ulcer clinic. Often I can refer patients to dermatology or orthotics if the patient has a foot deformity that they need a bespoke shoe to make for themselves. So we work very closely on with all different types of professionals in the NHS. The NHS is like a living organism, yeah. So you're never alone. You always depend on different type of professionals to work and to provide the best care for our patients. Next slides, please. Job satisfaction. To be a healthcare professional, you need, most importantly, to be able to like and to want to provide care. You need to be a caring individual, yeah? So, especially working for the NHS requires dedication. No one works for the NHS with the aim of becoming rich. We work here because we love to work for the NHS, and we work to be able to provide the best care for our patients. It's a work that gives good work-life balance because you can choose how many days of the week you would like to work for, so you have that flexibility. You do have financial stability, you know you're always going to get paid. You have your holidays, you can progress in your careers. As I said, NHS work through bands, so you newly grad, it's a band 5, and can you slowly progress into up to a band 9 if you want to become a pod surgeon. But if you want management and to become more a senior, you can become a band 7. It's very interesting because you can specialize, like my prior colleagues have said, you can specialize in different sectors. So for me, for example, I specialized in wound care, but some people can specialize in MSK, some people prefer to work just with kids. And so you have this variety, and especially if you choose, depending on the trust that you work for, your progression is quite quickly. And as I said, you need to want to make a difference. You need to want to make a difference within your team, but also in your patients' lives. Next slide, please. Okay, so Podiatry is a very medical profession, and you often, in the first year, you have to study your anatomy and physiology. And there's a huge array of routes that you can take as a podiatrist. Very interesting, you can become a CSI and specialize in forensics. You can do like I do. I work at hospitals and clinics for the NHS. Some trusts provide home care, so you can also visit patients in their own home. Some private podiatrists also do home cares. Some podiatrists specialize in MSK, and they provide services for sports, so for footballs or any sports, because you can develop, imagine, high-impact sports, you tend to develop some MSK problems. Sorry. You can work for the private sector, and for that you can either work for open your own clinic or work for somebody else, or you can follow the research route and or become an university teacher and work in the academia. There is also some people that goes a very different route that provide services for shoe company, for companies that provide products for podiatry like an athlete's foot, cream or emollients, and that's very different. You can also work for the Ministry of Defense, providing work, clinical work for hospitals that provide for the Ministry of Defense. And as I said, it's a profession that needs more professionals, so you're never short of work. Next slide, please. So what do we do? Sports injury. So we covered a little bit on the previous slides. So in the NHS, as I said, we're more focused in the wound care. So we provide either palliative treatment for patients that are prone to develop wounds, or we provide wound care treatment. And in this time, we see patients either weekly or bi-weekly. In the private sector, the sky is the limit. So they provide dermatological treatment, they provide neurosurgery, laser treatment for fungal infection or verruca treatments. They provide shockwave therapy. They even provide special nail extensions for patients that have had to have their nails removed or that find that nails unsightly. There is a special extension antifungal treatment for that as well. Biomechanic, we on private practice, you have a whole gait analysis equipment to provide insoles. Some podiatrists also work in the prosthetics industry, where they can help devise prosthetics for patients that have had some toe amputations or sometimes the forefoot amputation after trauma or due to diabetes. And it's a very, very interesting field because you can choose to just become a routine podiatrist and or otherwise work as a pod surgeon. So really the sky is the limit. Next slide, please. Okay, so I will speak in this sector more towards the NHS because that's my experience. So it's very important that you can work in a team to do teamwork, because often you're working in a multidisciplinary team, providing wound care together with diabetic nurses, vascular surgeons, orthopedic surgeons. So it's very important that you can get involved in a team setting. You need to develop your critical thinking because sometimes, well, often you need to think outside the box. You need to analyze why is this person developing these pressure ulcers here and there. So you need to constantly be revisiting your diagnosis and providing different, trying to find what's going on. Interpersonal skills, you're working with the public, so you need to have very good interpersonal skill and good communication. Often people don't understand my accent, but I always leave them to feel free to ask me to repeat as many times as they want. Emotional resilience, because especially in the NHS, our patients have chronic illnesses and they're very unwell. So it can take a toll on the patient, and that can reflect to us as well. So it's very important to have buddies that you can talk with about how this can impact your emotional well-being. And as I said before, you need to be a caring person, because you're going to be providing caring treatments for people, okay? And very good with the hands, because we do a lot of very small, delicate colors debridement. We work with sharps, and we have to enucleate the corn, so you have to have some dexterity. Next slides, please. A little bit about an impact of a few sample of patients that I made a huge impact with. It's like both of them, they are type 1 diabetes patients. They're in the early 30s. So the first one, his HbA1c was 130. Bear in mind, a good diabetic HbA1c should be 48. So he wasn't using his insulin because he was scared of having hypos. So his HbA was through the roof. And with weekly wound care that I was providing, I was also educating him on self-care. And just by being on top of him with insisting him, because often he missed his appointments, so I would call him before to remind him of his appointments, or making sure that I provided a late appointment. He was attending his appointment, and slowly I was educating him and pushing him to take his insulin and have better diet control. Just with advices, he managed to bring his HbA1c to 89, and I was able also, after several trials, to get him into a diabetologist clinic where he got the implant, so he now can access he can monitor his glucose with a device, and he can check his readings on his phone, and that made a huge difference. Unfortunately, he already had all the complications that diabetes can cause. So he has neuropathy, which is lack of sensation of the feet, and he has autonomic neuropathy. He's losing his sight, and it's just because, unfortunately, he didn't look after his diabetes for so many years. Similar case with another patient that was neglecting his self-care. Not only he has diabetes type 1, but he has lymphedema, and I managed to refer him to a lymphedema clinic where he was issued compression stockings, and he also had some self-care problems, and together we've been able to put him in the right track. And often I have to send patients to A&E because they have a foot infection, and we had some near miss of sepsis where patient came to see us a little bit too late, but we blue light them to A&E, and they were admitted in and IV antibiotics, and no sepsis. Okay. And podiatry for me really is about providing the best care. I do treat all my patients like if I was treating a family member, and how I would like to be treated. It's not an easy job. The job is very demanding because unfortunately we're a small team, but I do my best. I really do my best to provide the best care for my patients. Next slide, please. How to get into podiatry? Podiatry is normally a 3 or 4 year degree. You go from your A levels all the way to your university, but you can also have your GCSEs, your A level. You can go through your BTEC. So the team normally is mature adults. So I was a student at 32. I joined the university at 32. Often a podiatry student is a mature student on the second or third career option. prior from being a podiatrist, I worked in retail, I was a beautician, and I've had colleagues that worked in IT, colleagues that worked in marketing. I even had a colleague who was a lawyer before and found the job very cutthroat and decided to move to a healthcare profession. So that's how podiatry normally looks. I did have, our cohort was quite small, but I did have two colleagues peers that went straight from university to podiatry. Next slide, please. So that's the pathway from school all the way to a job career. Feel free to have a look later. Next slide, please. So as I was saying before, we are an aging profession body, because unfortunately not many people are interested in podiatry. I don't know why. It's a very, very interesting career, but people have this myth about feet, and feet is just another body part. So we are mature students. Often we are students that are on the second or third career. And because of we're mature students and we have professionals that have been doing this for 30 odd years, we are aging working force. So we will need more and more and more member of staff. We are, funnily enough, like nurses, we are a more female-centered cohort than men. Don't know why. We're just like that. Next slide, please. Apprenticeship. So the government is providing this new pathway to try and recruit more healthcare professionals, and apprenticeship is a great way because you get paid to study. So in my trust, we have several slots for apprenticeships, and you can earn £26,500 to study, and you get allowed holidays like any member of staff. You are given one study day and one study day at university, and 3 days you are in clinic. And it's a very hands-on approach where you are always with a podiatrist and you get to see all different areas of podiatry. It's a great opportunity for people like me who has dyslexia, perhaps, like I do, and ADHD, and prefer a hands-on approach. So it's very, very good. I wish at my time there was such option, but there isn't. So I did 3 years of university, and despite my dyslexia and being a foreigner, English not being my first language, despite all those difficulties, I graduated with a first-class degree. So if I could do it, anybody else can. I left some links there so you can see the pathways that you can join podiatry and the universities. It's 4 years for apprenticeship, but some universities are choosing to do 3 years to make it more interesting. And podiatry, as I said, is normally 3 to 4 years. It's only in Scotland is a 4-year degree, but all the rest of the UK is a 3-year degree. Next slide, please. The government offers some grants, so you can get some grants to study podiatry. You don't need to pay them back, and that's the link for the pay scales in the NHS. So it's good. You can start at £24,000, I think was when I started. I think we've had some pay rise recently, so that's the recent pay scale. Next, please. So the expectation salary is apprentices. As I said, you earn to study. It's a great opportunity. Our apprentices here in my trust, they're married and with kids, and they can earn to study. So it's and also the way that the curriculum is devised, you can easily accommodate your lifestyle to the degree. Newly graduate starts at band 5 pay. The apprentices in this trust is band 4. Some other trusts is band 3 pay. And also, you can earn the NHS band, but in the private practice, I think minimum is 40K, and the sky limit. I know people who have already planning their retirement at mid-50s because they have multiple clinics with multiple chairs where they rent, and they can make they make in a range of 250,000 to $1 million. So really, the sky's the limit. If you are a business thrive person, you can have your own clinic. So podiatry is an amazing option for career. Next slide, please. These are the universities that offer podiatry in UK. I come from East London, which is the only one who offers in London. And at the time I was living in London, so it was easily accommodated with my life, marriage, so it was easy commute. In Glasgow, it's a 4-year degree, as I said, and often those universities hold open days. I would really strongly advise you to go there. Next slide, please. So, summary. It's a very rewarding profession. It's a very medical profession. So often we have members that have tried different allied health professions like physiotherapy, and they couldn't get in. They tried dentistry and medicine, and unfortunately they couldn't get in. So they saw podiatry as an option, and they're very happy being a podiatrist because, as I said, it's very, very medical. So you do diagnose, treat, and medicate patients. It has loads of opportunity to you develop your expertise in many areas. If you're a career-driven person, you will grow in your career, especially in the NHS, and you need to want to be a caregiver, and you can earn to study, and you can have flexibility. So many of my colleagues, and like myself, they do NHS work and private work, so you have a huge amount of flexibility, and you do a certain type of podiatry for the NHS and a different type of podiatry for the private sector. So it's very flexible. And that's it.
Thank you. And thank you to all the guests that have joined us today in discussing or promoting their careers to you. Hoping that we've just given you some sort of inspiration there to kind of come and join us. So as always, we'd love to hear what you think of the session. Please scan the QR code and give us some feedback, negative or positive. All feedback is welcome, and it allows us to plan for the next sessions that we can offer to you. So thank you very much, and we'll see you for the next session.